Love you.
Don't be scared. It's going to be fine.
In the UK, some 3 million major operations are carried out every year.
I'll be there with you all the time, okay? We'll look after you.
But some patients' procedures are so complex, only the best surgeons can perform them.
Everybody happy?
Okey-dokey.
As soon as the patient is on the operating table, their life is in your hands.
Adam Brooks and Royal Papworth Hospitals in Cambridge are world-renowned for their pioneering techniques to treat conditions that few others dare to take on.
It's a bonkers job, kind of like something from science fiction.
But pushing the boundaries of modern medicine comes with great risk.
I've got to get this right.
Things can go wrong very, very quickly.
We've got a venous bleed.
You need to be able to accelerate from 10 to 100.
Don't pull, don't pull. Jesus, what's happening?
The surgeons bear the ultimate responsibility.
We have a problem. There's a big problem. Can you just stop talking?
When things don't go as well as they should, then you start to question, was it something you did?
I have operated with tears rolling down my cheeks.
Doing our job takes its toll, but being a surgeon shows you life is precious.
That's it.
Youth.
Come on.
Bravo. Woo! Happy days.
This is somebody's life, and it has to be done perfectly every single time.
Adam Brooks Hospital, Cambridge, where surgeons take on some of the most challenging operations in the country. A small number of procedures are so complex, they require 2 of the hospital's leading consultants.
If you have a moment, would you have a look at the op note from last night, just to make sure we've got all the detail right?
Yeah.
Operating duo colorectal surgeon Nicola Fernhead and urology surgeon Alex Cahoon have been working together for 10 years.
We're so used to operating with each other that often we don't need words to say what needs to be done next. We can often read each other's thoughts.
The urine stoma is always difficult in the exenteration patients. I would say at work, Nicola is probably one of my closest friends. I have implicit trust with her when we're operating together.
Hello.
Today, the 2 surgeons are bringing together their different specialties for the 9th time this year to perform one of surgery's longest and most involved procedures, a pelvic exenteration.
So it was the patient who's 52 years old.
The aim is to cure the patient of cancer by removing all the organs in the pelvis, including the bladder, prostate, and rectum. It's so complex that it can take 2 days to complete.
Total pelvic exenteration is one of the very biggest procedures we do, certainly within urology and colorectal surgery.
We'll take the nodal tissue following the externals down. You're clearing out the contents of somebody's pelvis, that's what the operation entails.
After the operation, with the patient's organs removed, urine and feces will pass into 2 stoma bags, which will sit on the outside of the abdomen.
It's a very hard choice for patients to make, caught in the place between a chance of cure and the changes that will come afterwards.
The operation is so life-changing that 1 in 10 people that need the surgery to survive turn it down.
You won't want jeans, will you?
Those 2, because they're quite baggy.
Deciding to have this major procedure is Stuart, who lives with his wife Sally and their 2 sons.
You said to take comfortable clothes for sitting around.
Yeah, it did. I've put your shorts in.
Yeah.
First diagnosed with bowel cancer 10 months ago, he's already had 1 operation, chemotherapy, and a course of radiotherapy. But he still has advanced cancer in several pelvic organs. Stuart will die without this major operation.
What's the alternative? The alternative, you get through all this treatment and you're still around in 20 odd years, or you don't, and you're not.
The surgeons have explained to Stuart and Sally the enormity of the operation.
I think that's when it really sank in, quite how big the operation was going to be. Because you can say, oh, we're taking bits and pieces out, but that is your husband's body there, and so much of it was cancer.
My mindset is get through it quickly as possible and get back to normal as quick as possible. Definitely something to beat. 2, 3. Forgot how hard you hit.
Stuart doesn't see me when I'm upset because I don't think it's helpful to him, and it feels really selfish.
3.
When I drop him off, I think that would definitely be on my mind that he might just go through them doors and not come out again. That's really hard.
Not the most talkative this morning.
No.
Yeah.
Love you.
Love you too. Where am I going?
There's now just 1 hour before Stuart goes to theatre, where the aim of the operation is to cure him of cancer. Nicola and Alex will need to go deep into Stuart's abdomen and pelvis to remove the cancer and the organs that have been affected. They must take out the bladder, prostate, rectum and lymph nodes, plus a margin of healthy tissue around the disease. A tumour on the kidney will also be removed. They will need to operate carefully as the organs are near to the body's biggest blood vessels, the aorta and inferior vena cava, and the major vessels that branch off them. Damaging any of these could cause a major bleed. Finally, with key organs missing, the surgeons will need to reconstruct how waste leaves the body, giving Stuart 2 stomas, one for solid waste and one for urine.
Should we kind of mosey in?
There's a 1 in 25 chance Stuart won't survive the operation. Nicola and Alex have been counselling him for weeks on the risks and what the surgery will mean for his new life.
There is a 100% chance of having 1 or more complication in the recovery period.
Have we got your wife's number?
Yes.
It changes the patient's life forever. They are living with 2 stomas, they're living with complete loss of sexual function, and sometimes with chronic pain within the pelvis as well.
All right.
See you shortly.
We'll see you up there soon.
Yeah.
Okay.
Right, go and find some scrubs.
For the 20-strong team in Operating Theatre 20, including 3 anaesthetists and 7 scrub nurses, concentration and focus will be required for at least 14 hours, and possibly 2 days.
Let's just start with the basics.
Anticipated blood loss?
I think we're looking at probably between 3 and 3.5 litres today. For any patient having extensive surgery, this is going to be the biggest day of their lives.
It's just the worry. I mean, there's so many possible side effects. And it's a big operation.
The stakes for them are individually very high, and it is our role to deliver the very best care that we can.
Look at that, you could have been a school teacher in a former life, Miss Fenton.
The operation is so long and complex that it has 24 stages, all of which are being listed so the team can monitor progress throughout the day.
It's very much a marathon rather than a sprint. So back, front, sides, join, staple. I think that's it. I think it probably is one of the longest duration of operations, and that's probably because we are right at the limit of what a human body can tolerate.
I think any patient who doesn't come to theatre scared has probably not quite understood what they're about to face.
Right, we're going to give you a bit of oxygen to breathe.
Have a good sleep.
Everybody happy? Happy to proceed? Happy? Good.
Nicola and Alex make a 35-centimetre incision from the bottom of Stuart's ribcage to just below his navel. They'll have to work deep in his body to get access to the cancer and organs which need to be removed.
What we're doing at the moment is putting in a wound retractor, which will both protect the edges of the wound, help reduce the risks of infection, but also acts as a retractor to open the abdomen and give us view and exposure.
Over the next 14 hours, they will carefully separate out all of the diseased organs from the surrounding tissue so they can lift them all out in one piece.
And I'll go for the large Langenbeck, thanks.
In this operation, physical and mental stamina is essential.
Thank you. Just so everybody knows, we're up to number 3 on the board.
You're also aware that you have a responsibility to keep calm.
Could we get that tied down?
So that if something untoward does happen, you can deal with it.
Down the corridor in Addenbrooke's, consultant neurosurgeon Alexis Joannidis is preparing for pioneering brain surgery.
The brain, compared to any other organ, is quite special in many ways because it does determine who we are as a person. And if we do surgery in certain areas, we can see changes in personality afterwards. So these scans are showing that there is an abnormality in the front of the brain, which is a tumor.
It's a glioblastoma, a brain tumour so aggressive it's incurable. But the more of it Alexis can remove, the more months or years he can extend his patient's life.
Unfortunately, this is the most malignant form of brain cancer we tend to see. The life expectancy is a few weeks to months. And it does highlight that life can be shorter and more precious than we might otherwise think.
Alexis's patient is 30-year-old Adam.
Just see you on the other side, yeah?
Yeah.
Yeah.
Tomorrow, hopefully.
Here with his mum, dad, and partner, Tasha.
Stay strong. Yeah, don't worry. Okay.
2 months ago, manufacturing operative Adam started having severe headaches.
Just woke up with an excruciating migraine. It was in the eyes, the ears, the face. I couldn't move, couldn't talk. It was agonising.
5 weeks later, with his symptoms still so severe he couldn't work, Adam's GP sent him to an optician for an eye test.
Straight away his face was dropped and he's gone, you need to go, A&E, right now. The doctor came and saw me and said, after an MRI and CT scan, that I've got a brain tumour.
Adam's tumour is large. It's about the size of a small apple. Tumours of this type usually grow within weeks. It could start affecting other brain functions and could precipitate a stroke.
The tumour's just, well, it's just been such a shock. It's all happened so quickly.
You wish it wasn't your child. You just wish it was you in that position rather than them.
Is this reception?
Yeah, I think.
The brain tumour is not the only change in Adam's life.
I've always wanted to be a dad. So in 4 weeks I've got my first child coming, a little boy. So I've got that to look forward to. First Christmas with him.
Without the operation, Adam could die within months. It's his best chance to live to see his son start to crawl. But how many months or years he has after that will depend on how much tumour Alexis can remove.
Love you. Love you too.
Adam's glioblastoma, more commonly found in people in their 50s and older, is particularly difficult to remove because the cancer cells diffuse into the surrounding brain.
Glioblastomas are infiltrative, and by that it means the cells extend into normal brain tissue. But we know that if you remove more grossly abnormal tissue from the brain, you can improve prognosis. Right, Adam, all ready? Yeah.
To give Adam as many years as he can, Alexis will be using a groundbreaking surgical aid only available across the NHS since 2019, called 5-aminolevulinic acid, or 5-ALA. Drunk 4 hours before surgery, this pink drink, as it's known, is absorbed by the most aggressive high-grade cancer cells, metabolizing inside them to make a compound that glows pink under UV light.
5-ALA helps us to remove more tumour than if we just use natural light alone, from about 30 to 40% to 60 to 70%.
The tumour, the size of a small apple, is in the frontal lobe, the part of Adam's brain responsible for creativity and imagination. To access it, Alexis must perform a craniotomy, cutting out a section of skull to expose the brain. To help him remove the tumour fully, part of the operation will be done under UV light, where cancer cells will glow bright pink due to the 5-ALA chemical Adam has drunk. That way, Alexis can take out as much of the tumour as possible.
The risks, we could have a permanent disability like a stroke, and also the small risk of, to your life from the surgery as well. Unfortunately, in brain surgery, there is no risk-free operation. If you run into a significant complication, then the consequences for the patient are a lot more profound than if you were to, lose an organ somewhere else. I'll just draw a mark on the correct side, which is the right side. Right. So, we're all done for now, so I'll see you downstairs.
Okay,
all right?
Thank you. Yep, thank you.
All right, excellent. See you later, Adam.
See you later.
Bye-bye.
Adam Brooks has 4 neurosurgery suites. Today, Alexis and his team of 9 will be operating in Theatre 22.
Okay, good morning, everybody. We're doing...
So, 5-ALA resection of a right frontal tumour.
Nervous now. Never had an operation before, so it's all a bit unknown to me.
I'm petrified. I can't bear the thought of losing him.
So I read in the notes you're expecting a baby.
Yeah, 32 days. So.
32 days, wow. You know what you're having?
Yeah, little boy.
Little boy, lovely. Think of something nice.
To reduce the risk of catastrophic brain damage during surgery, Alexis and the team will use neuromonitoring to help navigate safely through the brain. 35 electrodes are attached to Adam's legs, arms, tongue and face.
I'm just going to put one more on the front of the...
Throughout the operation, the tumour and surrounding brain tissue will be stimulated with a low voltage current. If these electrodes pick up this signal, Alexis will know that he's affecting the part of the brain that controls the movement of limbs.
Happy to start?
Yes.
The first step is to make a 12-centimetre incision across Adam's head to reveal the skull.
The most important trait of a neurosurgeon is that you need to be very, very cautious and meticulous. Knife again.
With the scalp clipped back, Alexis must now remove a section of skull to access the brain. Drilling through 7 millimetres of bone.
Operating on the brain is a high-stakes situation. I feel responsible for every patient that I decide to operate on. And just a bit of dura coming up. Try not to make the patient worse.
In Theatre 20, Nicola and Alex are an hour into their marathon operation to remove widespread cancer and all the organs from Stuart's pelvis.
Look, there's a little bit of mesocolon still.
Yeah.
So let's take the ligature across.
There is a very old saying that a good surgeon needs an eagle's eye, a lion's heart, and a lady's hand. I hope I have all of those.
Before they remove the cancerous organs, they must locate and keep safe the structures they'll need later to reconstruct Stuart's urinary function.
Why don't we find
Ureter?
ureter? They say in unison.
Urologist Alex needs to find and preserve Stuart's 2 ureters. These are 30-centimetre drainage tubes that carry urine from the kidneys to the bladder.
I mean, we're very sure we're not on ureter there, aren't we?
Once the bladder is removed, the ureters will be connected to a stoma tube, which will take urine to a bag outside the body instead.
The ureters are always to be treated with respect. They are very delicate structures.
I think plane's there, isn't it? What do you think?
Yeah.
I think it's there, yeah.
They need the ureters, or the reconstruction won't work. But finding such small tubes buried deep in the pelvic cavity is proving difficult.
My finger's here, but I'm just checking which is the right side.
When I can't see the ureters, I am using the ends of my fingers to feel for a muscular tube within the fat tissue to try and locate the ureters.
So this is presumably the vessel going down.
To add to the challenge, scar tissue from the previous bowel cancer operation has distorted Stuart's anatomy, making everything even harder to find.
So there is the vein. Agreed? Can you see the vein? Could you just gently open that so that we're not pulling on it?
2 hours into surgery, and Alex and Nicola have still not found the ureters.
Let's open a little bit more here. Now, what's that?
It's a friend.
This was the one that was drawn in. It's ureter.
Ureter. Let's have a
So we found the right ureter.
blunt nose right angle, please.
They may have found 1 ureter, but the lengthy search means they're behind schedule. And specialist renal surgeons Tony Riddick and Grant Stewart have arrived in theatre to remove the kidney tumour.
How are we doing?
We're doing all right. We haven't yet found a left ureter, which is making Alex a little bit jumpy.
Right.
Give us a bit more time. Now, just check ureter's not in there. It shouldn't be.
It shouldn't be, but nothing is where it should be.
Nothing looks right.
I keep looking at this all the time. I don't know if it's this or...
That's it.
Thank you for finding it.
No, that's fine. I didn't want to disturb you earlier.
Mr. Simulus has divined the ureter for us. Right, I'm now happy.
It's
I've
all right
seen
now
the
that we've
wiggly
seen the
tube. I've
ureter.
seen the wiggly tube.
With both ureters safe, renal surgeons Tony and Grant can get to work removing the 6-centimetre tumour attached to the bottom of Stuart's right kidney.
Are you ready?
Yeah, room for
Right, room for you.
Yeah, marvellous.
Kidneys are normally accessed through the back, but in this operation, the surgeons need to go deep into the pelvis to reach them.
It's not the easiest mobilisation because it's quite a deep.
So far, they're only 7 steps into the operation, with another 17 to go.
One always has one eye on the clock. But if something can't be done, then you have to spend the extra time to do it. And you're always just concentrating on getting the best you can for that particular patient.
Can you feel the tumour at all, Tony?
I'm not sure, actually.
Hi.
When Stuart finally comes round from his mammoth 2 days of surgery, he'll be getting a visit from Amanda and Anna.
It looks so much better than it did.
Looks so much better.
They're part of Addenbrook's dedicated team of stoma specialist nurses, something that Amanda's friends don't always understand.
Why do you want to have a job where it's just dealing with poo all day? Oh, I'm not squeamish at all. The gorier, the better. At the end of the day, these people aren't having stomas because they want to have them. It's a stoma or death, really, sometimes.
Because Stuart will have no bladder or rectum, urine and faeces will be diverted to 2 holes, or stomas, which the surgeons will create in his abdomen. Attached to these will be plastic bags to collect the urine and solid waste.
You've got your stoma that sits on your tummy, and out of there is where you will poo.
Stomas provide a lifeline for over 175,000 people in the UK, allowing their bodies to perform an essential function.
People with stomas have conditions ranging from cancer to inflammatory bowel disease such as colitis and Crohn's, diverticular disease, trauma.
Hi, Kathleen.
Hi.
Kathleen's temporary stoma was formed 3 days ago, following the removal of a section of colon.
How have we been doing?
Well, a little bit better each day.
Good. People will say, well, that's it, that's the end of my life. I walk down the street, will somebody smell me if they walk past me? If I go to a function or for a dinner, you know, out for dinner, is my bag going to leak? And I say, no, there's no reason you don't go back to a normal life. This is all yours to take home.
Great.
An important part of Amanda's job is teaching patients how to manage the bag. On average, a bowel stoma like Stuart's will need attention 1 to 3 times a day.
So do you want to have a go at cutting the template like you said yesterday?
The rapport we get with patients, they can be very emotionally upset. You'll see them at their good times, at their bad times, and just acknowledging that, helping them through the bad times.
For Amanda's patients, and for Stuart, having a stoma may take getting used to, but it's also their best chance to live a longer life.
And then you can see through the window here, your stoma.
It's weird.
Weird.
Can't believe that's part of me.
I think the more you explain to the patient, the less fear they have.
She makes me feel as though I know what I'm doing, and I haven't a clue. She just doesn't make you feel that you're an oddity. We've done it.
You did.
And then a normal wash.
In Theatre 22, neurosurgeon Alexis is trying to extend 30-year-old Adam's life. He's removed an 8x5 centimetre plate of bone from Adam's skull.
Just get rid of all the bone dust, see?
He must now delicately cut through the dura, a protective layer of tissue a millimetre thick, to reveal the brain.
Let's have Adson's and dural scissors. Thank you. When you do brain tumour surgery, it is something that does seem quite odd. You have somebody's skull open, you are looking at their brain. It's much more dynamic than what you might think. It's pulsatile, it's soft. You need to handle it very delicately. There's a vein just underneath there.
As Alexis peels back the dura, he can see the tumour for the first time.
It's all this rubbery kind of texture.
Yeah, I can see.
Yeah, so it's a very clear boundary there. Adam's tumour is big. It's around 6 centimetres in diameter, which, considering the size of your brain, does take up a lot of space within the brain. Just make sure they're not under tension. Good. That's better.
Different parts of the brain control different functions. The tumour is growing in Adam's right frontal lobe, responsible for memory, emotions, impulse control, and problem solving, and just in front of the area responsible for movement.
Your brain is who you are, so there is a balance on how much tumour you can safely remove. And if we follow that round, that's also boundary.
Alexis must determine where the tumour's edges are and how far it reaches into the brain. Cutting too much could severely damage Adam's brain function.
You can see subtle personality changes, things like apathy or flat mood, but you know that 2 or 3 more millimeters, then you could be damaging normal brain. So it's fine, we're aiming for here.
He relies on the electrode monitoring to ensure that Adam won't be left paralyzed when he cuts into the exposed brain.
But let's put the electrode strip next.
He places an electrode strip next to the tumor on the brain's motor cortex, responsible for movement. Together with the electrodes already placed on the fingers, toes, tongue and face, they will monitor signals between the brain and Adam's muscles.
Upper limb, contact 1.
So it just needs to be pushed a bit farther in, I guess.
Alexis then uses a probe to send a low voltage electric signal into the point of the tumor he wants to test. Neurophysiologist Sarah Martins will monitor the electrodes to see if they react to this signal. If they do, it means this part of the tumor is in the area of the brain that controls muscle movement and should not be removed.
Right, so Sarah, just stimulate a bit, cortical.
Yes.
To know if it's safe to cut into this bit of the tumor, he's looking for no response.
At 10?
10.
Yeah, stimulating.
No response.
And again.
No.
And again.
No.
Good, okay.
Now he needs to identify where the most aggressive part of the tumor lies, where the cells are fastest growing, and so the most important to remove.
Right, we'll need lights off now. Wash.
The 5-ALA liquid that Adam drank before surgery is absorbed by brain tumor cells, but for unknown reasons, makes only the most aggressive ones glow bright pink under ultraviolet light.
I need to see the fluorescence. By using fluorescence-guided surgery, we can increase the resection of highly abnormal tissue and improve prognosis. It's particularly useful when you're trying to decide what are the margins of your resection. I don't see very much.
I can't see any fluorescence.
It should be Alexis's most critical guide, but there's no fluorescent glow.
I don't see any. If you don't see fluorescence at the outset, the one thing that you sometimes worry is whether the fluorescence has worked. Now, it doesn't happen very often, but sometimes you don't see a signal. It could be that the brain tumor just doesn't take it up. Okay, fine. So I guess we can do it in the normal light for a bit. Okay, wash, keep it moist.
Alexis is forced to make his first cut into Adam's brain without the help of the 5-ALA liquid.
We'll just do a bit of resection there and just develop the boundary a bit.
He must work by eye, hoping he'll come across the high-grade cancer as he cuts.
Because that looks quite normal down there, see that?
Yeah.
And this one looks abnormal. So we'll just keep tracing our way around. Without fluorescence, it's not always straightforward to judge what is normal brain and what is tumor within the brain. It's never clear-cut.
If Alexis can't find and remove the aggressive, most malignant cancer, which should be glowing pink under the UV light, the prognosis for Adam is poor.
Nothing, 0.
In Theatre 20, surgeons have been working on Stuart's marathon operation for 7.5 hours.
So tumour's off, repairing kidney.
Renal surgeons Tony and Grant have successfully removed the kidney tumour, so Alex and Nicola return to theatre. But they're only halfway through the 24 steps of the operation.
Right, if you're looking at the board, we're now ready to start stage 12.
They still need to mobilise and remove the rest of the cancer and all the organs in Stuart's pelvis.
So I'd say we're about halfway through the pelvic phase. So. You love it really, don't you? Oh, dear.
They have to work with great care and accuracy. Stuart's bladder, prostate, rectum and lymph nodes all need to be removed. But among these organs are vital blood vessels, the aorta and inferior vena cava, which branch off into vessels that carry blood to and from the heart and legs. Damage to any of these could cause a fatal bleed.
I think we're getting close to the aorta, judging by the jumping.
You feel like
yes,
you're close to the aorta.
I'm jumping.
These vessels carry around 2 litres of blood a minute. Separating the organs away from them is the most high-risk part of the operation.
The thing that I worry about the most with this type of surgery is bleeding, and bleeding. That's what we're keen to avoid because of the immediate threat to the patient's life.
As the surgeons make their way towards the pelvic tumour, they're clamping and cutting small branch veins that join directly to the major vessels.
If it's okay, I'd quite like just to finish this bit because we're right on a really perilous bit. I just don't want to break concentration whilst we're on this.
Can you see this? This vein can cause you so much trouble.
That flimsy bridge in between, I think, needs to go before it tears.
I'd rather get it out. It's not a slip of the knife that's usually the problem. The most dangerous point is if undue traction is put in blood vessels. Okay, just relax a second.
Scissors.
We've got a venous bleed.
A tributary from one of Stuart's main blood vessels, the common iliac vein, has been torn.
It could be made much, much worse if we in any way pull on the vein.
It's a life-threatening situation.
If there is a significant bleed, step number 1 is keep your cool.
Of course there is adrenaline involved, but there's absolutely no need for panic.
They need to work fast to stop the potentially fatal bleed.
It's very intuitive. Nicola will know that I'm going to press on whatever area is bleeding to control it. And I will know that she'll be preparing stitches to repair it.
This is going to go on for a little while.
When you're waiting for news from the theatre, it feels like time stopped. There's so many things that can go wrong that can change how he's going to be able to live his life afterwards. And it's not just, can he survive the operation? It's like, there's so many things that could go wrong.
Maria, can I have some more wash, please?
Yep.
In Theatre 22, consultant neurosurgeon Alexis needs to find the most aggressive cancer cells in 30-year-old Adam's brain.
So I guess let's just open all of this.
Yeah.
Adam's been given the 5-ALA pink drink, which should be absorbed by high-grade cells and make them glow under the UV light. But so far, Alexis hasn't been able to see them.
This looks more normal, it's actually slightly rubbery.
Instead, he's been cutting by eye around the less aggressive low-grade part of the tumour, which doesn't show as pink. This needs to be removed too, but it's the fast-growing part of the tumour that will have the biggest impact on Adam's length of life.
Okay. I need to see the fluorescence. Now if we push the lights into dark mode again, I'm going to have another look. Thank you.
Alexis cuts deeper into the brain.
Aha, look at that.
There it is.
There we are. So that corresponds to the area of enhancement. That's all pink as well. Oh, look at that. There you are, pink.
But the fluorescence is in a more dangerous position than Alexis first thought. To remove it, he must cut closer to the tracks deep within Adam's brain. Nerve fibers, which carry signals to make muscles move.
So we should probably extend our resection, Marjorie. All this will go. One thing we worry about is if we keep resecting further and further back, of potentially reaching the tracks that would move the muscles on the left side of his body. We're pretty much on the posterior medial border of resection, so
Okay.
Do you have anything here?
Alexis uses the electrode monitoring to see how far into the brain tissue he can cut without causing catastrophic damage. No response means he's safe to proceed.
Stimulating?
No.
No. And again?
No response.
No, very good. We have to balance the need for removing as much tumor tissue as we can against the risk of causing a permanent and unacceptable deficit like paralysis.
Every millimeter Alexis cuts around the tumor takes him closer to the nerve fibers responsible for movement.
The most challenging part of the operation is judging when to stop. So I think this is the boundary of normal brain, I think. So we'll just have to amputate here. Let's see if there's anything here. So that's clear in terms of fluorescent signal.
After an hour of cutting around the tumor, Alexis is ready to remove it.
For now, let's just take the mass out. Yeah. Yeah.
Right. Can I have a big wash, please?
Alexis does a final check for any remaining high-grade cells.
This is obviously the area we're mostly concerned about.
The more of these left behind, the worse Adam's prognosis.
Do you see anything?
I can't see anything.
No. This looks completely negative.
All the visible cancer has gone.
Lights on, please.
Top lights on, please.
When you finish any operation on the brain, the main thing you worry about is how will the patient wake up? Try, let's have the bone.
Can I have the Langer back, please, Maria?
You don't know whether you've caused something which has led to permanent problems, a stroke, or possibly the patient not waking up at all. Adam, you're just waking up.
Let go, open wide. It's all gone very well.
An hour later, Adam is fully awake, and Alexis can do some initial cognitive checks to see if Adam's thought processes are working normally.
So I just have two small bits to check with you. Can you tell me what this is?
Yep, it's a pen.
All right. And what color is this?
Green.
Very good.
It'll be another week before Adam will know how much the operation is likely to extend his life. It's approaching 8 p.m. In Theatre 20, Alex and Nicola are trying to stop bleeding from the tributary of a major blood vessel.
Do we have a little bit of saline, just a few mils?
It is really good just knowing that there is somebody at your side who is capable not just of helping you deal with it, but also of making sure that it's likely to be more successful.
That's quite reassuring.
By applying pressure and a stitch, they've managed to get control.
What we're going to do now is mobilise the bladder. Are you sure?
But they're behind schedule. Whilst the kidney tumour is gone, they still need to free all the cancerous pelvic organs so they can be removed in one piece.
We need a new ligature design to go round corners.
A reticulating ligature.
Or a robot. Excentrative surgery, it requires a lot of dexterity at times and really, really fine movements, coupled sometimes with strenuous manoeuvres in terms of trying to remove a tumour. Tying backwards and blind, huh?
Yeah, that you were operating, I feel. It felt good though.
Let's try again.
It does take a physical toll on you, certainly when you're 12, 13, 14 hours of surgery. You do know that you've been operating for the whole day.
They're now ready to take out the tumour and the organs all together.
Right, the specimen is coming out. Let's contour back to you. Thanks, Lorraine. Thank you. If I put it down, could somebody pack pelvis?
Stuart's bladder, rectum, prostate and lymph nodes are out. The hope is that the specimen contains all of the cancer and a big enough margin of healthy tissue.
Yeah, we've got it.
Happy?
Yeah, we've got it. Feels there's really, really good tissue over the tumour there. So the majority of the tumour is in here.
It's immensely satisfying to know that you've given Stuart the best chance of cure you can.
Can we have the large specimen pot?
You could use the
This
catheter.
is specimen E, which is total pelvic exenteration. It is the point at which you realise that you've actually delivered what you set out to do. There's a moment of satisfaction before we start the process of putting the patient back together again.
It's so late in the evening, it's decided the reconstruction must wait until tomorrow. But there's one more task before they can stop for the night.
Ligature, thanks.
Now that Stuart has no bladder, they must harvest part of the small bowel, which will be repurposed as an exit tube for urine from the kidneys to a stoma hole in his abdomen.
Oh, that was easy. Almost like I'd done it before.
Once or twice, maybe 3 times. Swab coming out.
It's almost 15 hours since the first incision. Stuart's wound is being packed with sterile materials and covered over.
You can let the small bowel fall into there so the small bowel doesn't sit on the swabs.
For now, he'll be kept anaesthetised, with his abdomen still open, and taken to intensive care for the night.
Thank you so much for your help. Really. Hopefully see you tomorrow.
But for the procedure to be a success, Nicola and Alex must return in the morning to totally rebuild Stuart's waste system so it can function, leaving him with 2 stomas for urine and faeces.
Surgery is very personal. If a patient has suffered as a result of something you've done, you do have a sense of personal burden that goes with that.
At 8:45 the next morning.
I might have to go and have a quick regenerative coffee, I think.
And Nicola, Alex and their team are already back in Theatre 20 and heading into their second day of Stuart's pelvic exenteration.
But you're right, it is exhausting. But you kind of knew it was coming. I mean, that's why we booked the 2 days. It was all planned out.
Right, shall we start? Okay. Oh, it's like a workout. I think when you come back a second day after prolonged surgery, you're aware that Stuart won't remember everything that we took out of his pelvis, but he will remember the position of his stomas and whether they work.
Let's just settle him first and put him on the vent.
Because that's the thing that's going to dictate his quality of life.
Slide.
If everybody's happy, let's go ahead.
So far, they have completed 16 steps of the procedure. Today, there are just 8 remaining. Their main task is to create a way for urine to leave Stuart's body, now that he has no bladder. They will take the kidney's drainage pipes, the ureters, and attach them to the length of small bowel they harvested already. This will then be passed through a hole in his abdominal wall, and a bag will be attached to collect the urine.
So let's keep our urine. It's making lots of urine.
Fabulous urine output.
The tiny tubes that carry urine from the kidneys have to be carefully sewn to the section of small bowel or conduit, using 2 continuous stitches, 1 to 2 millimeters apart.
Okay. Skin knife, please. Good grief. It's going to be a long way through.
With the ureters attached, the conduit needs to be brought to the surface of the abdomen through the stoma, the 4 centimeter wide hole they've created. This is where the conduit will be attached.
So it's better to have this one slightly too loose rather than too tight.
It needs to fit perfectly. If the flow of urine is restricted by any obstruction or tightness, it could back up and cause kidney failure.
It needs to have 2 fingers breadths as the optimum size, so that we don't want to pinch. So it's a little bit narrow here. Just a tiny little bit of diathermy. Looks good. There we go.
Let's see if we can just give you a bit of... Where is it sticking? It's sticking here.
But the thickness of Stuart's abdominal wall is making it difficult to get the conduit through the hole they've created.
Try a slightly different angle. Take your time, take your time. It's going to be fine. How's that?
It's not great, is the honest answer.
Nicola and Alex must make this work. Stuart needs this stoma, otherwise there is no way for urine to leave the body.
So there's plenty of length. So there's one other option. We just make this aperture a bit bigger.
Okay, it's a giant hole now.
I know, but it's got to come out and it's got to be alive.
It's coming.
It's the furthest it's gone in so far.
Finally, the conduit is through to the surface.
Yep, there we go. That's it.
Good. So we've got a position for the conduit. Let's let it relax.
Now Stuart has a stoma for urine, along with another the surgeons have created for solid waste from his bowel. After more than 27 hours in theatre, Stuart's operation is coming to an end.
We're going to have to close this really carefully here.
At the end of the operation, there's an overwhelming sense of satisfaction. There aren't many jobs where you would work for 20 hours continuously and expect not to feel tired. It's natural.
You happy?
Yeah, looks pretty good. I think we've been through everything.
It's going to take him a while to get better, that's for sure.
It always feels good to tick things off. The most important thing is to tick the final one, which is closure.
Stuart will be closely monitored in intensive care for the next 3 days.
Right, thanks very much, everybody. Take care. All of those of you who've done 2 days, appreciate it as well. Thank you.
Thank you. Hello, it's Nicola Fernhead from Addenbrooke's. We are very positive. The next few days are going to be pretty hard for him. It is going to take him a while to get better.
Stuart's returned home after 4 weeks in hospital.
I'm managing the stoma bags and the stomas quite well. It's just they're so unpredictable.
Stuart's always got a good attitude towards his recovery. He's very stubborn and positive.
They've had good news from Nicola and Alex. Not only did they manage to take out all the cancer, but the margins were also clear. Stuart is cancer-free.
It was the best news I heard. I mean, every time I say it, I practically burst into tears. I find it hard not to.
What is that?
I've got no idea. It says the beginning of a new chapter.
It's immensely satisfying when you're able to tell somebody that you've taken out all of the cancer. You've achieved what we set out to do.
Don't sit around doing nothing. Make the most of what chance you've been given. Don't waste it.
Good morning. All set? Yes, very much so. It's going to be a good day.
All right. Stuart, from the minute we met him, he was absolutely determined.
Right.
And he certainly has gone through all his treatment, really embracing it and getting on with it. That really takes courage.
Good luck, Donny. You too.
After recovering at home, Adam's returning to Addenbrooke's with his mum, dad, and pregnant partner Tasha.
It's a matter of hoping now.
Yeah, everything crossed.
He's here to check there are no post-operative complications and to find out what his prognosis is.
Hi, Adam.
How you doing?
Hi, Wendy. Do you want to come through?
Yep.
Take a seat.
Thank you.
So, Adam, how have you been doing at home?
Yeah, I've been okay. Yeah, not too bad at all, considering.
And what about the headaches you had before the surgery?
No,
They've
okay.
gone?
Yeah.
Okay.
Alexis has results from the post-op scans and the pathology lab who've examined Adam's tumour.
The overall prognosis is better. It's about 3 to 4 years.
It means Adam should, at the very least, be able to enjoy the first 3 years of his new son's life.
It's more positive than we were expecting, so...
Yeah, no, that is positive. The better prognosis means I can plan more for the near future with my little boy and partner, family and stuff, so before worrying too much too soon about whether it's going to be back.
You right?
Yeah.
By doing the surgery, it's first stage of a journey to keep Adam as well as possible for as long as possible.
He'll undergo 8 months of chemo and radiotherapy to continue his treatment.
When seeing patients like Adam, you cannot predict how this disease will behave in any one individual. You could call it uncertainty, but on the positive side, you could call that hope.
Next time,
1, 2, 3.
Being told I'd have to have surgery.
major reconstruction surgery,
Ooh, don't pull.
Yep.
Yeah, otherwise we're in trouble.
where failure is not an option.
Was the other one not draining at all?
No.
Ultimately, the buck now stops with me.
Careful.
Oh, sorry.
Such a bloody nightmare. Nothing is guaranteed.